My dear students, in this video, I am going to discuss some points on the newer modes of mechanical ventilation. And among the newer modes of mechanical ventilation, I am going to touch upon only the following ones: the adaptive support ventilation and the IntelliVent, the automatic tube compensation, the smart care pressure support, proportional assist ventilation, and NAVA. Although you have to remember we have one thing, that these newer modes offer some advantages on the basis of our understanding of the knowledge of, of the actions and the requirements of the modes on particular physiological conditions. But none of the studies have seen that there is an overall benefit in terms of mortality or other hard outcomes when you compare newer modes against the conventional modes. However, they offer some advantages, and these features can be used to reduce the duration of ventilator days and the duration of ICU stay, quite to the convenience of the patient and the family. Let us start with this case. A 60-year-old male patient of ARDS is ventilated on volume control ventilation assist, ventilatory assist with a tidal volume of 6 mils per kg of predicted body weight with a PEEP of 10 centimeter water and an FiO2 of 0.8. Over the next 48 hours, oxygenation improves, sedation is reduced, patient starts triggering his breaths, and he switched from the VCV assist to pressure support ventilation mode. But there his respiratory rate increases, becomes 32, along with double triggering variable tidal volume with increasing patient ventilator asynchrony. And this continues despite optimization of the pressure support for poor synchrony. And finally, there was no other alternative but to switch back from pressure support to volume control and give sedation. But this problem keeps recurring. So in this situation, what are the possible solutions? This we have to dig into the problem to see the importance of the benefits of the modes. So if we look into the conventional modes, we find that since the lungs are dynamic and heterogeneous and patients breathe differently at different times, so keeping in mind that also the conditions like ARDS, COPD, and pulmonary fibrosis have non-uniform lung mechanics because of heterogeneous involvement. So there are often problems like overdistension leading to the villi, or under support causing patient fatigue, and poor synchrony requiring greater sedation or paralysis. So these are the problems which we are encountered by most of us in our day-to-day experience with conventional modes. And because patient effort and the ventilatory delivery mismatch persists, so the double triggering, ineffective efforts, increased work of breathing also persists. So conventional ventilation modes are not optimal for every patient, every lung, or even in every phase of illness when the physiology of the lungs is transforming from the disease state to the healthy state or the vice versa. And some of these challenges are mitigated in the newer modes of mechanical ventilation. For instance, in ARDS, where the need is to give good lung protection, some advantages are offered by adaptive support ventilation and the IntelliVent. In COPD, where the problem is a dynamic the expiratory flow limitation leading to air trapping, where the proportional assist ventilation adapts to this increased resistance. In GBS and in myasthenia, where the problem is the weak effort of the patient and where the NAVA detects the neural drive, or in post-operative patients where there is variable demand and the adaptive modes, particularly proportional assist ventilation, also alongside ASV can be useful. Let us start with this adaptive support ventilation. The core concept of adaptive support ventilation comes or stems from this equation, the original Otis equation, which is for the minimum work of breathing. So this is the equation which many of us can easily forget because it is difficult to remember. But what is easy to remember is that this adaptive support ventilation, the ventilator calculates the compliance and the resistance by breath to breath analysis from the delivered volume and pressure and the flow pressure relationship. Now, since this is able to do that, this intelligent ventilator, what clinician needs to set is to set the percentage of predicted minute volume that needs to be delivered. For example, if it may be 100%, it may be slightly more or slightly less. Supposing if it is 100%, the adaptive support ventilator or the adaptive support ventilation mode ensures that this minute volume is achieved, and minute volume is the product of the respiratory rate and the tidal volume. But instead of making any arbitrary choices, it selects that respiratory rate and tidal volume pairing, which causes the least work of breathing. This is also known as the Otis optimal point. If you look into the figure on your left side, where tidal volume is plotted on the y-axis and the respiratory rate is plotted in the x-axis, we can find that is along this entire curve, which go from up the point A to the point B, with intermediate points B, C, D, and E. Everywhere, the amount of minute volume remains the same, whether it is at the cost of an increased tidal volume or at the cost of an increased respiratory rate. But if you see the slope of the curve, you can see and understand that the point C is the one where this pairing is such that the point is equidistant from the both x-axis and the y-axis, and therefore is likely to have the least work of breathing. Now, this point C is then the Otis minimum optimal point, and the ventilator, the ventilator mode, ASV, reaches this point where at that particular respiratory rate and the tidal volume delivers or achieves the requisite percentage of minute volume which the clinician has set. So this is the basis on which it acts. And if you look into the figure onto your right, where you see the volume, targeted volume along the y-axis and the respiratory rate along the x-axis, you can find that there can be four regions. The first region, one, where the volume target is met, but the respiratory rate is less. So in these patients, what this adaptive support ventilation will do is that it will increase the respiratory rate, or it will give some kind of ventilation which akin to the SIMV or the pressure support SIMV, etc. If the patient is in zone 2, where the patient has both met the tidal volume as well as the respiratory target, in this case, the ventilator is not going to give any supporting breath. In the third zone, where the patient has achieved the rate but is not achieved the tidal volume, is missing on the targeted tidal volume, here the ventilation is actually going to deliver the volume, or it will, other words, it will be a pressure support ventilation. But if the patient is in zone 4, where neither the respiratory rate target nor the tidal volume target is achieved, the mode behaves like a pressure control mode. So, because it is an adaptive support ventilation, it is able to calculate the compliance and the resistance, look into the patient, get the feedbacks, and decide whether it has to behave like an SIMV or pressure support, or pressure control or do nothing. So this is the intelligence nature of the adaptive support ventilation. So here the clinician sets the targeted minute volume in terms of percentage of the normal MV based on the patient's ideal body weight and the maximum P plat, which is also called the ASV pressure limit. PEEP and FiO2 must also be set, and then the P max must be set around 10 centimeter water more than the ASV pressure alarm limit. So on your left, you can see the settings which the clinician has to make in terms of the height, gender, minute volume, trigger, ETS, and the tube resistance compensation. And on your right, the table shows that these are the limits which are there inbuilt in the mode. If one wishes to change them, they can change it, but these are the ones which will finally determine that at what level the ASV pressure alarm limit will give alarm. So based on the patient's lung compliance, airway resistance, and the dead space as calculated using this Radford nomogram, you can remember it, an optimal minute volume, tidal volume, and frequency that would minimize the work of breathing is actually calculated by the ventilator. So now do this, what happens is that the ventilator gives a minimum of 3 test breaths in the beginning when it starts ventilation. So these are pure pressure control breaths of more than 15 centimeter of water. And during this test breaths, the ventilator measures the inspiratory time, the inspiratory pressure, the compliance, and the resistance. And on the basis of these measurements, it calculates the expiratory time constant, or the TC expiratory, as you can see, and then uses this expiratory time constant with the estimated dead space and minute volume on the base calculated, or which is calculated on the basis of the ideal body weight to calculate the targeted respiratory rate. And finally, with these measurements, it sets the targeted tidal volume and respiratory rate within the safety window, that is within the safety window of the set alarm limit. So during ventilation, depending upon the lung mechanics and their transformation as they recover from the disease state to the healthy state, the pressure limit increases or decreases within the set ASV pressure limit to achieve the targeted tidal volume, and the minute volume percentage can be adjusted manually. So if after a certain time the clinician doesn't need 100% MV and wants to reduce it to 90 or 80, one can do so. The ventilator will automatically make the rest of the calculations. So in the first case, we used ASV settings, targeted minute volume of 100% predicted, and automatic adjustment of respiratory rate, tidal volume, and inspiratory pressure was achieved. And within 2 to 4 hours, the respiratory rate came down to 20 to 24 minutes. There was better synchrony, stable tidal volumes within this 6 to 8 mL per kg, and reduced work of breathing. Now, one particular extension of ASV is the IntelliVent ASV, which is the patent of the Hamilton, where a fully automatic ventilation mode, which has some additional special settings to autopilot the ventilation. Now, as we know that in normal adaptive support ventilation, we set the minute volume percentage that we read, and we also fix the PEEP and the FiO2. But in the IntelliVent ASV, oxygenation and ventilator settings are set automatically according to the targeted EtCO2 and the SpO2. So here the ventilator is able to, based upon the EtCO2 and the SpO2 of the patients, it can automatically target the ventilatory settings. So there is no need to give actually PEEP or FiO2, and it allowed the ventilator to adjust it in its own way. So that is just as you can see in this diagram, conventional ventilation to ASV. We set the percentage of minute volume, give the PEEP and the FiO2 required, and in IntelliVent ASV, there is automatic control of the CO2 elimination and automatic control of oxygenation. And based on the feedback, that is patient's EtCO2 and the SpO2. And it will calculate and determine the PEEP, FiO2 and the percentage of the minute volume. Now, this intelligent ASV gives us two important things. One is called the heart-lung index, which is a spatial parameter to indicate the extent to which the hemodynamics are affected or can be affected by the applied positive pressure. So, as we know that there is a heart-lung interaction or during mechanical ventilation, and because of the venous feeling, which has its bearing on the stroke volume. So this is based on automatic analysis of the variations in the monitored SpO2, and it's expressed as a percentage in this intelligent ASV. And as I said, heart-lung index is measured, and if the heart-lung index is more than 15% as a default, the delivered minute volume can have a strong influence on the hemodynamics, or in other words, it can cause hypotension. The second important feature is a unique SpO2 option with advanced artifact rejection, because as we know that IntelliVent uses the principle of positive pressure ventilation for assessment of hemodynamic status, and the pulse oximeter to see that the if the pulse oximeter which is compatible with the ventilator is from Nihon Kohden, and it incorporates advanced automatic rejection of artifacts, and this actually increases the accuracy of the measurement of pulse pressure variation. So this is also an important point which one needs to remember about intelligent ASV. Now, weaning with intelligent ASV is easier because it provides an optional automated weaning protocol. And again, it's a patent. The name is patented by Quick Wean. So this Quick Wean progressively reduces the pressure support by monitoring from the phase 1 to phase 3 by monitoring for readiness to wean criteria, and provides an operator configurable weaning protocol. And once the patient tolerates this reduction in the pressure support, the patient automatically passes through fully controlled spontaneous breathing trial. And finally, the ventilator indicates that the patient has passed the SBT and gives the indicator in green to wean off or to extubate. Let us come to second case. A 70-year-old male with severe COPD is on mechanical ventilation for acute exacerbation with hypercapnic respiratory failure. The mode is pressure support of 12 with a PEEP of 5, but the problem is patient is having tachypnea with a respiratory rate of 32. Patient is showing distress. Ventilator waveforms are showing double triggering, flow mismatch, and the working diagnosis which is made on the basis of these findings is patient ventilator asynchrony. Now, why is this happening? Because in COPD, there is already increased airway resistance secondary to expiratory flow limitation, and there is also variable patient effort. And because the pressure support ventilation gives fixed pressure, it is not matching demands always. And in some instances, there is under assistance, and some it is over assistance. So this is the problem which is causing the asynchrony. So how to fix this problem using newer modes of mechanical ventilation? So these are the ones which provide some the benefits or mitigate the problem. These are the proportional modes of ventilation, because these modes work by amplifying the effort of patient's respiratory muscles activity, and thereby they improve the imbalance between the capacity and demand. So this capacity and demand mismatch leads to all the problems. But if that can be stabilized early enough with the suitable ventilatory modes, then probably it can avoid certain complications. Now, modes of proportional ventilation already readily available in the clinical practice or dedicated ventilators can be either of two types. One, they can be NAVA, that is neurally adjusted ventilatory assist, or they can be proportional assist ventilation with load adjustable gain factors, which we indicate as PAV plus. So PAV plus is proportional assist ventilation with load adjustable gain factors. This is the more accurate term, and the other one is the NAVA. So the NAVA delivers the inspiratory assist in proportion to the diaphragm electrical activity, which it can continuously measure. And the proportional assist ventilation plus, that is the PAV plus, they will deliver the assist in proportion to the instantaneous flow and the volume which is generated by patient's inspiratory effort. Like if you can see in this image, there are certain points which point to increases in the PAW or the airway pressure. But immediately below, you find again this is the esophageal pressure versus time, that those where we have high airway pressure, they actually are showing lower esophageal pressure. So the lower esophageal pressure is indicated the need for greater airway pressure or greater proportional assist ventilatory support. So this is something which needs to be known, and also to understand is that in the flow versus time, if you see that this is the point in which there is actually no flow. So these points are also important. Now, if we have to set the ventilatory mode, the settings will show the percentage support or gain, which is the most important setting. And this determines how much work the ventilator does. Typically in ICUs, we should start with 50 to 60%. Keep the PEEP as per the disease condition, keep the FiO2 same as any other ventilatory mode. The backup ventilation in the safety settings is the most important safety feature. And since the proportional assist ventilation requires spontaneous effort, so the patient can go into apnea. So backup respiratory rate and mode should be always kept. So this is important to ensure that the patient is safe. Trigger sensitivity, usually flow trigger and cycling and inspiratory time, that is automatically adjusted and there is no need to set manually. Regarding monitoring the parameters, the percentage work of breathing, the target should be the patient doing 30 to 50%. But more importantly, the ideal comfort zone varies from patient to patient. And only when the estimated compliance and the resistance which is displayed on the ventilator, and that helps understanding the disease physiology, is displayed. This shows most of the time very difficult to translate into practice so that the benefits can be actually measured. But one has to ensure that the tidal volume is neither too low nor too high in order to avoid fatigability and lung injury. The respiratory rate, again, high respiratory rate would indicate under assist, very low over assist. So accordingly, they should be adjusted. So the percentage of support in practical settings should be between 50 to 60. The PEEP anywhere between 5 to 8 centimeter of water can be sufficient. FiO2 as required, backup respiratory rate 10 to 12, and trigger is again flow trigger. So the practical tips that one should importantly remember in such patients is that we have to increase the support or decrease the support based on whether the patient is distressed, tachypneic, versus whether the patient is passive with low effort, etc. So if we say that, the next question which will automatically enter into anybody's mind is how much of the work of breathing should the ventilator actually do? Now, if we look into NAVA, which is another form of proportional assist ventilation, in contrast to proportional assist ventilation plus, this here, a nasogastric or orogastric tube with electrodes is placed in the patient to detect changes in the electrical activity of the diaphragm. And this is more than 60 times per second. And when the diaphragm contracts, the phrenic nerves deliver the signal to breathe. The ventilator, what it does, it measures the strength of the activity and provides an appropriately sized breath test based on patient's own effort towards respiration. So NAVA is superior to conventional triggering modes as respiration is directly guided by the activity of the patient's CNS rather than external flow or pressure sensors. The settings in the NAVA are important. We have to set the NAVA level or the gain, that is which determines how much pressure is delivered per unit of diaphragm activity. And although there is an equation that is airway pressure is equal to NAVA level multiplied by the electrolytic diaphragmatic activity, the end that maximum minus minimum whole thing plus P. So typical starting values should be 0.5 to 1 centimeter water per microvolume. The positioning of the catheter is very important. Between specialized nasogastric tubes with electrodes must be positioned at the diaphragm level and confirmed by proper waveform, ECG signals, etc. Backup ventilation is an essential safety feature. So one has to set and one should set apnea time, backup mode, and or if there is no EDI signal, one can look for automatic switch to the modes. The cyclical, that is the end of inspiration, that is settings are by neural base with ventilator cycles of when the electrical diaphragm activity is around 70% of the peak. So what are the parameters to be monitored? Look into the NAVA level, which should be 0.5 to 1 centimeter water, P 5 to 10, FiO2 as required, apnea time 3 to 5 seconds, backup mode with either pressure support or pressure control. So if the EDI is very high, more than 15 micro, then we have to increase the NAVA level to give more support. If the AD has very low values or it is less than 5, then we decrease the NAVA level and avoid over resistance. So the NAVA settings can be simplified in the form of an equation, that is the NAVA level plus P plus FiO2 plus backup safety with titration guided by diaphragm electrical activity. Now, smart care is again another the patent of Draeger, where they have this special mode in which they have modified it in a way that it passes through 3 stages of adapt, observe, and maintain, and finally gives its decision to extubate. So because this ventilator is more intelligent than others, so the guiding the patient inside a comfortable zone of normal ventilation to a minimum level of pressure support is the first step, which is to be followed by this, which is called adapt. The next is to observe, which is there is supervised spontaneous breathing trial at minimum level of pressure support. And finally, to maintain, that is by keeping the patient under automatic control after he or she has been declared ready for separation from mechanical ventilation. So what it tries to do, this tries to see that in the core of this image, there is normal ventilation. The periphery outside this core, we can find a lot of factors: hyperventilation, insufficient ventilation, hypoventilation, tachypnea, unexplained hyperventilation, severe tachypnea. So all of these are conditions which tend to pull out normal ventilation away from the central core. And the ventilator actually pushes those problems so that the mode, that is the ventilator, can give the necessary support through the normal modes. Now, if you look into this diagram, the recordings here, we can see how it can record and it can show the trend. So it tries to keep the patient within normal ventilation zone and brings them back on track if it can diagnose otherwise. So based on the respiratory rate, tidal volume, ET CO2, etc., the pressure support will change. Of course, the key factor would be that whether it is hypoventilation or severe tachypnea or insufficient ventilation. central hypoventilation, etc. So smart care pressure support is automated pressure support titration using respiratory rate, tidal volume, and EtCO2 to keep the patient in a comfort zone and facilitate the weaning. Let us come to the third patient. The third case is a 55-year-old male with sepsis due to pneumonia. The patient has improved after 5 days of mechanical ventilation, hemodynamically stable, awake and following commands. There is good oxygenation with FiO2 of zero point 0.4 and PEEP of 5 as patient is planned for the spontaneous breathing trial. The initial spontaneous breathing trial patient was on PSV. The mode was pressure support ventilation. Pressure support was 7 centimeter water and PEEP of 5. And after 30 minutes, the respiratory rate was increasing to 32. Patient is anxious with accessory muscle use and the tidal volume is borderline. Now, if you look into this, this is something which many of us have experienced many times, that whether this is true weaning failure or whether this can be due to anything else. This is where one needs to understand the automatic tube compensation. This states that when a patient breathes through an ETT, the tube creates additional airflow resistance and patient must generate extra pressure, which increases the work of breathing. So automatic tube compensation mathematically compensates for this resistance in real time. How it does that, if you know the principle, it becomes easy for us to understand. As the pressure drops across the endotracheal tube, it is directly proportional to the square of the flow. Higher inspiratory flow gives rise to higher resistance, and the ATC delivers just enough pressure to offset this. So automatic tube compensation means that when a patient is breathing through an endotracheal tube, the tube creates additional airflow resistance that patient must generate extra pressure, which this increases the work of breathing. Now ATC mathematically compensates for this resistance is real time. So the principle is that the pressure drop across the endotracheal tube is calculated. If it is high inspiratory flow, then higher resistance, and ATC delivers just enough pressure to offset this, then it is better. So there is step-by-step mechanism to understand, to deal with it. The clinician inputs like ET tube of ID internal diameter of 7 to 8. The ventilator continuously measures instantaneous flow. It also uses stored resistance models and calculates pressure drop across the tube. After that, finally, it applies equal and opposite pressure. So this is something which is viewed as virtual removal of endotracheal tube resistance in some journals between 24 to 26, although nothing concrete has been published so far. So the key features of automatic tube compensation are the flow proportional support. It works in both phases, that is inspiratory and expiratory. It is adjustable with the percentage of automatic tube compensation. If 100%, there is full resistance offset, whereas if it is adjustable to 70 to 80%, then it is partial and it can be more physiological. The clinical applications of this automatic tube compensation lies in weaning and extubation readiness, where it is best used. Case simulates breathing without ETT and often used during spontaneous breathing trial. In difficult weaning, where it reduces the artificial work of breathing and prevents fatigue, as well as in COPD or high resistance states, where it helps overcome added airway resistance. So automatic tube compensation reduces the work of breathing more precisely than pressure support ventilation. So if we compare all the types, the modes in ASV or interleavant ASV, the control is closed loop. The best use is general ICU, and the key advantage is its automation and lung protection aspect. For proportional assist ventilation and PAV plus, the control type is effort is proportional to the effort. Best use is seen in weaning, COPD, and the advantage is that it helps to retain the natural breathing abilities of the patients. NAVA has a purely neural control, best use in patients with asynchrony. And again, the key advantages is the same, that the synchrony is the best. The smart care pressure support, automated pressure support, is the control type best used during weaning, and it also requires realistic breathing. So the expected overall benefits of this newer metaphors are that it improves the synchrony. For example, the NAVA, it uses electrical activity of the diaphragm, and from that it can work for better matching of efforts. The second benefit is the proportional support, especially with like proportional assist ventilation, where support varies with patient effort and avoids over resistance or under resistance. Closed loop or intelligent ventilation like ASV, intermittent ASV, smart gear, they automatically adjust the respiratory rate, tidal volume, FiO2, and PEEP. They aim for predefined targets with HuCO2 and SpCO2 and SpO2, and on that basis, the other parameters are calculated. It also reduces the clinician burden because of standardized care, reduces the human care, and assists in patients who are taken to big hospitals where assistants are less experienced. So the take home message in the end would be, for best synchrony, we have NAVA more than pressure, proportional assist ventilation more better than PSV. Best automation is intelligent ASV. Best winning tool will be smart care pressure support or automatic tube compensation. Physiological breathe limits are the PAV plus or the proportional gains assist ventilation with adjustable gains. And trigger delay elimination is again a function which can be best suited for those with NAVA. So thank you very much.